that you can tell a lot about the condition of a musical artist's heart by listening to the lyrics of their songs. For instance, Billy Ray Cyrus, I don't think his heart is very good because he says, "Don't break my heart, my achy, breaky heart." And then he even goes on to say his heart may blow up and kill a man. Oh dear. Celine Dion, on the other hand, thinks that she has a very strong heart because for Titanic she sang, "Near, far, wherever you are, I believe that the heart does go on," and on and on. However, the guys and girl at Roxette probably would have fancied Cardiology if they hadn't made it big in music, because according to them, they listen to your heart. I wonder if they would have heard an S3 gallop there, which speaks to cardiac failure. Anyway, hi guys, it's Dr. Ryan here again. Thank you for joining me on yet another high impact algorithm in internal medicine. Thank you for those who are liking and sharing and subscribing. So we're going to be breaking into the realm of cardiology today, and I'm quite excited about this. Now, I just want to mention something before we get going. Normally, I restrict the length of my videos to about 10 minutes or so because I don't want it to be too laborious for you guys. But because there's just so much to say about heart failure, please forgive me if I go over and above this. And I also want to mention that this talk is not going to be focusing on therapeutics and management. It's just meant to give you an overall approach to the plethora of etiologies that exist behind heart failure. So let's get going. Heart failure is a clinical syndrome that develops as a result of structural or functional impairment of ventricular filling or the ejection of blood. Symptoms of heart failure include dyspnea, cough or orthopnea, paroxysmal nocturnal dyspnea, fatigue or lethargy, weight gain, nausea, early satiety, and abdominal discomfort. Now, physical findings of right-sided heart failure include an elevated jugular venous pressure, more affectionately termed the JVP, right ventricular heave, right-sided gallop, ascites, and lower extremity edema. Now, the physical findings of left-sided heart failure include end inspiratory crepitant rales on auscultation of the lungs, a left-sided gallop, a laterally displaced apical impulse, pulsus alternans, and cool extremities. Now, the lungs may be clear in the context of chronic left-sided heart failure. Now, heart failure can be associated with what we term a reduced left ventricular systolic function or a preserved left ventricular systolic function. We'll be talking about these. Normal ejection fraction is above 50%. Heart failure with reduced systolic function is associated with eccentric hypertrophy, whereas heart failure with preserved systolic function is associated with concentric hypertrophy. The causes of heart failure with reduced systolic function can be separated into the following subcategories. We speak about cardiovascular causes, toxic infections, and others. And the causes of heart failure with preserved systolic function, so-called HIF or heart failure with preserved ejection fraction, are separated into those involving increased afterload, valvular disease, infiltrative disorders, genetic conditions, and others. Specific pharmacological agents have been shown to improve survival in patients with heart failure with reduced systolic function. Outcomes have been largely neutral in patients with preserved systolic function. So I've also got a couple of fun diagrams, once again, courtesy of Mr. George Muniz over at medcomic.com. Now, conceptually, when you think about something going wrong with the heart, I like to think of it in terms of different levels. Endocardium, implying the valves, myocardium, pericardium, or maybe there's some kind of conduction disturbance or something wrong with the aorta. So this is outlining the different kinds of cardiomyopathy. The three most famous ones we know: hypertrophic versus dilated versus restrictive. And hypertrophic, what we have is diastolic dysfunction or HIF, heart failure, preserved ejection fraction. There's a risk of sudden death in young athletes and a thickened left ventricular wall. You can see it's a nice, fat, thick ventricle here. Versus the dilated cardiomyopathy, where there's enlargement of all cardiac chambers, systolic dysfunction, or heart failure with reduced ejection fraction. This is the most common type. Then we have the restrictive, where we have very rigid ventricular walls with diastolic dysfunction. This is the least common type. Now, when we speak to dyspnea and heart failure, we speak to the New York Heart Association classification, class 1 through 4. As you can see, class 1, there's no limitation of physical activity. It's a happy heart. Ordinary physical activity does not cause symptoms. But in class 2, there is slight limitation of physical activity, but the patient is comfortable at rest. Ordinary physical activity causes symptoms. But here you can see the ball is getting dropped, so the heart is getting progressively weaker. Lastly, there's marked limitation of physical activity. The patient, yes, is comfortable at rest, but has less than ordinary activity, which causes symptoms. And in class 4, severe limitation and discomfort with any physical activity. Symptoms present even at rest. So it gets worse as you progress from class 1 to class 4. right? And here we're speaking about the concept of systolic dysfunction versus diastolic dysfunction. So systolic dysfunction means that your ejection fraction is reduced, usually below 50%, and that's what we call heart failure with reduced ejection fraction, versus diastolic dysfunction where you have an EF which is preserved, or otherwise called HIF-PIF, heart failure with preserved ejection fraction. And remember that these two can coexist, right? So in systolic dysfunction, quickly, there's impaired contractility with a thin, weak heart muscle, low ejection fraction. So you see the tail here, which represents the ejection fraction, is low. And the characteristic thing you get is the S3 gallop. And a nice way to notate it here is systolic, right? Like lab da. And remember that the S3 is more closely associated with the S2 than with the S1. Right? By S, I mean sound. Okay, and the causes of systolic dysfunction, systolic etiologies, ischemic heart disease, chronic hypertension, dilated cardiomyopathy, myocarditis. We're going to be talking about this in the algorithm. Versus diastolic dysfunction, the situation here is that of impaired filling or relaxation. You got a stiff or a thick heart muscle. The EF you can see is preserved here, and there's a normal ejection fraction with the S4 gallop. And the way they notate that is diastolic, right? And remember that the fourth heart sound is more closely associated with S1 than with S2. And the diastolic etiologies are, lots of them: hypertension with left ventricular hypertrophy, restrictive and hypertrophic cardiomyopathies, fibrosis, amyloidosis, sarcoidosis, constrictive pericarditis, hemochromatosis, valvular disease, and aging, right? So let's get stuck into our algorithm. So we broadly classify heart failure, looking at 49 possible etiologies, split into those with reduced systolic function, or preserved systolic function, otherwise called heart failure with reduced ejection fraction on the left or preserved ejection fraction on the right. The possible etiologies behind reduced systolic function are cardiovascular causes, toxic, infectious, and other. Under cardiovascular, think about, like we said, stuff involving the endomyopericardium, or it could be a conduction problem, right? So it could be ischemia, tachyarrhythmia, something involving the valves like aortic regurgitation or mitral regurgitation, anemia, and shunt as well, which can cause high output cardiac failure. Toxic causes, there's 5 we're going to speak about. Alcohol. Remember, alcohol is associated with a beriberi, which is thiamine deficiency. This is usually the wet beriberi associated with heart failure. And the dry one is associated with Wernicke's and Korsakoff syndromes. And then, of course, cocaine can cause it. Amphetamines, anthracyclines, thyrotoxicosis is well another cause of high output cardiac failure. Watch out for that one. Infectious etiologies include myocarditis, Chagas disease, which is caused by Trypanosoma cruzi, right? HIV and sepsis as well, which embarrasses ventricular myocardial function. Others, of course, familial, postpartum, very important, right? Don't want to, miss this one. Especially during pregnancy or just after pregnancy in the puerperium. Malnutrition is often caused. Takotsubo is the famous stress-induced cardiomyopathy causing apical ballooning and so forth. Cirrhosis can cause high output cardiac failure, as can acromegaly, as can Paget's disease, muscular dystrophy, giant cell myocarditis, and idiopathic. Then hopping over to the right side of the algorithm, the 24 causes of heart failure with preserved ejection fraction, those which involve increased afterload, and the poster child for that is usually hypertension, right? The increased force that the heart has to pump against in order to get blood out. Hypertension, the other one is hypertrophic obstructive cardiomyopathy. Remember the picture of Holcomb we went through in our mid-comic earlier. Copulmonale affecting the right side of the heart and coarctation. Valvular issues, a lot of stenosis going on, aortic stenosis, mitral stenosis, tricuspid regurgitation, pulmonic stenosis, tricuspid stenosis, pulmonary regurg. Infiltrative issues, we said, like amyloidosis, sarcoidosis, iron, lymphoma, and eosinophilia. And then genetic issues as well, like congenital heart disease, Holcomb, hemochromatosis, glycogen storage disease, and Fabry's disease. Other stuff to think about is pericardial disease, especially in the setting of constrictive pericarditis. Scleroderma is associated with it. Mediastinal radiation, sorry about the typo there, and idiopathic. So, as you can see, this was a mouthful, man. 24 causes of heart failure with preserved ejection fraction, 25 with reduced ejection fraction, giving you a grand total of 49 etiologies behind heart failure. Now, do you know that we're getting to the heart of things, right? So I just want to mention that even though I am a third-year registrar in internal medicine here in South Africa, I am also a Christian. And when we look into the Bible, in the book of Luke chapter 14, verse 2 to 4, it describes this instance where Jesus was at a certain Pharisee's house, and there in front of him, the scripture says, was a man suffering from dropsy. Now, another version of the Bible will say the man actually had swelling or edema. Now, I'm not sure whether this was due to cardiac failure. It could be, the differential diagnosis for swelling is quite broad. It could be nephrotic syndrome, it could be protein-losing enteropathy, it could be mixed edema, and so forth. But It goes on to say, Jesus asked the Pharisees and experts in the law, is it lawful to heal on the Sabbath or not? But they remained silent. So taking hold of the man, he healed him and sent him away. So even though there is a place for medicine in bringing health and in treating disease, I also believe in the power of healing through Jesus Christ. The Old Testament says that he is Jehovah Rapha, which speaks of healing. And the book of 1 Peter 2:24 says, he himself bore our sins in his body on the cross, so that by him we may die to sins and live for righteousness, for by his wounds you have been healed. So I pray that even as we go about our tasks in being physicians and doctors, we will not forget the spiritual aspect and believe that there's also power in prayer. And thank you so much. So this was a mouthful with heart failure. Don't forget to like and subscribe and share. And I will see you tomorrow with another topic in cardiology and our 28th algorithm in internal medicine. Hope you stay well.